Hey, this is a quick talk about VV ECMO. In the background, you can see the Golden Gate Bridge. ECMO is sometimes called bridging therapy. Function and benefits of VV ECMO. Basically, VV ECMO just provides respiratory support, unlike VA ECMO, which also provides hemodynamic support. It removes blood, it oxygenates it, it exchanges the CO2, then it returns the clean blood back to the heart. It essentially carries out the work of the lungs, similar to a ventilator, but it also quickly corrects the hypercapnia. While doing so, it avoids ventilator-associated lung injury. Some vent settings that you can use when using VV ECMO, you can set your PEEP to a PEEP of 10, basically to prop the lungs open. Generally like to use a low tidal volume between 50 and 200 ml, and a respiratory rate between 10 to 20 breaths per minute. There are several indications for VV ECMO, actually more appropriately stated uses for VV ECMO, because a lot of the uses are actually off-label. But rescue therapy, common use, basically it's used for any potentially reversible severe acute respiratory failure, for example, status asthmaticus, in which we see a 95% success rate. ARDS, aspiration pneumonitis, pulmonary embolisms, especially with concomitant use of TPA, ECOS, and thrombectomy. It's also used as a bridge to transplant. Also, VV ECMO became very popular during the H1N1 epidemic in 2009, in which it was used for severe viral pneumonia. And we found 70% rates of success with H1N1. More recently, it's used in the COVID pandemic in 2019 as well as 2020. In addition, VV ECMO can be used to basically rest the lung. It minimizes the barotrauma, which would lead to pneumothoraces as well as air leaks, and thus it reduces fibroproliferative changes of ARDS. As I mentioned, it's used in life-threatening hypoxemia, severe hypercapnia. It's used as a bridge to transplant. There's a score called the Murray score, which is basically suggestive of appropriate use of ECMO. As you can see at the bottom right of the slide, if you're talking about PEEPs of 14 or higher, you're already getting Murray score of 4. You should already be thinking about ECMO or already started ECMO. If you have a P to F ratio of less than 175 or even less than 100, you're already at a score of 3 or 4. Murray score of 3 or 4, in which ECMO discussion should have already been started. So there's no absolute contraindications for VV ECMO, except obviously if a condition precludes the use of anticoagulation, then you're going to have to think about risk-benefit discussion before starting ECMO. But there are some recommendations in which one should kind of consider not using VV ECMO, or relative contraindications, one of which includes unwitnessed cardiac arrest or unknown time down, because at that point you're talking about patients that may have anoxic brain injury. In addition, progressive or chronic non-recoverable respiratory diseases is another that needs to be considered as well. If a patient has a severe emphysema, very low FEV1 or very low PFTs, then really this is the case where we're talking about patients that have a bridge to nowhere. Obviously, unless they're on the transplant list or transplant recipients, then that changes. Patients with advanced malignancies or recent hematologic malignancies as well. Patients that have graft-versus-host disease in post-transplant patients, patients with severe pulmonary hypertension, patients with right heart failure, particularly right ventricular failure, because if you think about where is the cannula going in patients receiving VV ECMO, it's going in the IJ and into the right heart. So if you're depositing oxygenated, freshly oxygenated red blood into the right heart, yet the right heart's unable to pump it out, then you're really not making a reasonable use for this VV ECMO. You should either consider no ECMO at all, or at that point consider using some VA ECMO as well. Obviously, if a patient has a terminal or advanced condition, including HIV that's end stage or AIDS, bone marrow recipients, especially those that are severely immune suppressed with severe fungal infections, because if you think about the cannula sitting in the vasculature for a week, maybe 2 weeks at a time, it's going to be a nidus for infection. Complications of ECMO can include bleeding, especially considering that patients are going to be on a heparin drip. In addition, patients can clot the circuit, actually. Thrombus formation in the circuit is pretty common, especially if there's low flow or the RPM is set low. In addition, there can be blood loss, and that's blood loss in the circuit, similar to how CRRT patients end up losing some blood. Despite returning the blood back to the patient, there's still going to be some blood that is lost. Patients can also have thrombocytopenia. This is due to the platelet interaction with the circuit itself. Air embolism is also a dangerous complication. One needs to be careful, especially when inserting the cannula in the IJ. Just like doing a central line, you should wait until there's blood return out of the cannula coming outside of the patient to ensure that there's no remnant air in the cannula. And when connecting it to the external circuit as well, to the connector, you need to be certain that there's no air in the connector itself. So sometimes clinicians or physicians may top off the external circuit with saline flushes before connecting the two to ensure that there's no air in the circuit. In addition, just like any procedure that we do, there's a risk for line infection, especially in these cases when the line is going to remain in the body for 1 to 2 weeks. It serves as a nidus for infection. Now, we're all well too familiar with this slide, which shows mild, moderate, and severe ARDS. And we see ECMO all the way down on the far right-hand corner, sitting at about P to F ratio of 50 or 75. In 2020, we're actually should be considering ECMO slightly sooner. Once you start thinking about prone positioning, once you start thinking about neuromuscular blockade, you should also be thinking about ECMO as well. Here you can see a single site insertion in a pediatric patient. Now, the benefit of single site is that you avoid the femoral cannulation, and thus you have an easier time ambulating your patient. Not to say that patients that are femorally cannulated as well can't ambulate with assistance. They can, but it's just much easier to ambulate with a single site cannulation. Also, using ECMO as opposed to ventilation gets the patients off the sedation, off the analgesia sooner, and gets them ambulating sooner, all of which have been shown to improve mortality. This slide shows the single site Avalon bicaval double lumen catheter. The double lumen catheter allows for return and removal of the blood at the one insertion site. Also, the blue blood or the deoxygenated blood enters the cannula from the IVC, and the red blood or the oxygenated blood exits the cannula at the right atrium at the level of the tricuspid valve and shoots across into the right ventricle. You can see the bicaval aspect of the cannula right above. And if you cut the cannula in the cross-sectional area, you'll note that there is a double lumen in the inside, which I'll note on the following slide. Now, in this slide, you see an image that was actually published back in 2011 by Brody and Bichetta in New England Journal of Medicine. You have two panels, one on the left and one on the right. I'll step-by-step go through each one. So first, starting with the left. The left shows a two-sided approach to VV ECMO cannulation. You have an insertion site that goes through the right IJ, and it extends down into the RA. And you have a second insertion site in the femoral vein, which extends into the IVC. Venous blood is withdrawn from the femoral vein into the drainage cannula and sent to the pump. That blood then passes into the oxygenator. This is where gas exchange takes place. Then it's reinfused back into the venous system through the right IJ. And in this case, the lungs simply serve as a shunt of oxygenated blood. Also, with this two-side approach, a portion of the oxygenated blood can actually shoot down into the IVC and inefficiently get sucked back into the femoral vein cannula and then, to some degree, cause recirculation to occur. Now, consider the panel on the right. This shows a single-site approach to VV ECMO. This is a very similar concept. However, there's a bicaval dual lumen cannula that goes into the IJ and extends into the right atrium and continues down into the IVC. you can see an example of that cross section of that dual lumen cannula at the bottom of the screen. The blue blood and the red blood sitting inside the cannula. Now, venous blood is withdrawn through the ports above and below the heart. So to speak, blood is drawn from the SVC and from the IVC and sent again through the drainage cannula in a counter-current fashion up through the IJ, sent into the pump, then into the oxygenator, where gas exchange again takes place, and fresh blood is then created and infused back through inside through the IJ, through a counter-current as opposed to the blue blood that was sent up. And it's important to note that this red blood then is reinfused in the right atrium at the level of the tricuspid valve. So fresh red blood shoots across this tricuspid valve directly into the right ventricle, thus minimizing the recirculation problem, which I just noted with the 2-site cannulation catheter above. So this next slide here is to highlight the function of the oxygenator. It basically shows how the ECMO pump receives the blood, the deoxygenated blood, and it pumps it into the oxygenator. The oxygenator itself has 2 chambers. It's separated by a semi-permeable membrane. More specifically, it's actually described as a microporous membrane. One side of this oxygenator is called the blood side. This is where blood travels. And the other side is the gas side. This is where the fresh gas travels. It's also known as the sweep gas. Gas exchange occurs between the oxygen and carbon dioxide across this membrane. Finally, the oxygenated blood is then reinfused into the patient, as I described in the previous slide. Also, you need to recognize that the composition of the gas on the gas side of the oxygenator membrane is determined by adjustment of a blender, which mixes room air with pure oxygen for delivery into the oxygenator. And lastly, there are settings and parameters which need to be monitored. You have the pump speed where you set the RPM, and this modifies the flow rate. You have the inflow and outflow pressures, also known as pre and post oxygenator pressures. These are useful for troubleshooting the circuit. They can identify clots, kinks, and suction events. Suction events is when the cannula is sucking against the inside of the vessel and you get decreased flow. You have the sweep gas, which controls how much CO2 is removed from the blood. A higher sweep removes more CO2. Some systems may differ, but generally there's a larger adjustment and a more fine-tuning adjustment. And you can coordinate this with the minute ventilation on your ventilator. There's the FiO2, which is adjusted by the oxygen mixer, and you can monitor this by ABGs and monitor for signs of recirculation. There's also the heparin drip, which needs to be monitored by PTTs, and you need to remember there's areas of stagnant or sluggish flow, especially in the inflow circuit, and especially when weaning and turning down the flow rate. Remember, when weaning the sweep and the FiO2, you can also titrate up your ventilator settings. In conclusion, I'll leave you with these references, and thank you for listening.